involvement workshop to talk about end-of-life care in Leeds. So thank you all for coming. Like Adam said, we are recording this session, so if you prefer to have your camera off, that's absolutely fine. But there's a lot of people who want to come that won't be able to make it, so we want to make sure that it's on the website and people can see what we've discussed. I'm going to hand over initially to Jill, who's going to introduce herself and just do a few quick introductions.
Hello, I'm Jill Pottinger. I'm I'm a GP by trade, and I'm also the clinical lead for end-of-life care and also the chair of the end-of-life population board. And first of all, I'd just like to thank everyone for giving up their time and coming to help us in this really important piece of work. So we really do appreciate your involvement with this. So we thought, first of all, we'd just like to, there's an awful lot we've got to get through, as always, in these kind of meetings. But if we could just go round and just briefly, if everyone could just introduce who they are and maybe a very quick of why they're attending today, that would be really helpful before we get into kind of the presentations and the actual workshop itself. So if I start off, I'll hand over, if I give names as we go round, and I'll try and get everyone as best I can. So Chris, do you just want to introduce yourself first?
Yeah, so I'm Chris Bridle. I work for the ICB in Leeds, that's the Integrated Care Board, and it's my job to make sure that all the boards are thinking about the needs of members of the public when they're making their decisions.
Thank you. Anne Heeson?
Yes, good morning. I'm Anne Heeson from the LS 2526 PPG, and also we've just reformed our new surgery PPG, fingers crossed.
Thank you. John Curtin?
Good morning. I think a few folk here know me. A whole range of involvements as a volunteer, from the CCG to the Digital Board of West Yorkshire, ICB. I also have been for the last 11 years a carer for someone who's now at the stage of, we're looking at palliative assessment, not quite palliative care yet. I'm also I'm part of the current Network Data Lab work on unpaid carers, and I think the end of life protocols need to look at the unpaid carers as well.
Thank you. It's just Kausar.
It's pronounced Kausar, like the car. Hi everyone. Yeah, my name's Kausar. I'm a sibling carer. I've got two brothers with learning disabilities, challenged behaviour and epilepsy. And I do a little bit of work with Leeds Uni as a care educator, and quite a few things in the community. But it's a long list.
Thank you. Anne Herworth?
Hi, I haven't any prestigious titles like you folks there. I'm just Joe Public joining after seeing how my mum, unfortunately, who lives under the Wakefield Authority, was treated at the end of life. I'm hoping that Leeds will do a damn sight better job, and that's why I'm interested.
Thank you. Liz Thompson?
Yeah, I'm a volunteer at New Wortley Community Centre and also involved with Touchstone and with Live Well Leeds. My ex-husband, with whom I am in happy touch, is in the early stages of dementia. He also has a lot of physical pain problems, which makes his life very uncomfortable. Maximum pain relief at the moment in patches. Thank you.
Thank you. Jane Robinson?
Hi there. I manage Leeds Bereavement Forum, so obviously bereavement is a part of, or the end of life care.
Helen Smith?
Hi all, my name's Helen Smith. I work for the ICB in Leeds, the Integrated Care Board. I'm a head of pathway integration, and one of the areas that I lead on is end of life care. And when I say head of pathway integration, it's really about bringing partners together and working and coordinating in partnership. So that's predominantly what my role involves. Thank you.
Thank you. Kerry?
Hello everyone, my name's Kerry Jackson. I'm the Chief Executive of St Gemma's Hospice. So our building is based in Moortown, but we provide palliative and end-of-life care services to the whole of East Leeds, so for people both as inpatients in the hospice and also in the community. And we also provide education services and bereavement support. Thank you.
Thank you. Jenny?
Hello everybody. My name's Jenny Baines. I work at the Integrated Care Board, working on the pathway integration team. So that's kind of looking at the pathways across organisations and services for end of life and frailty.
Thank you. Charlotte Hilton?
Hi, my name's Charlotte. I'm a graduate management trainee of the NHS, but currently on placement at Forum Central. So this is not an area I've come across much before, but just trying to figure out where I might be interested in putting my time to best and serving people of Leeds best.
Thank you. No, sorry, it's Rachel. My screen suddenly all shot round, but Rachel next, please.
Morning, everyone. I'm Rachel Mooring. I'm a project support officer at the Integrated Care Board, and as part of my work, I've been supporting some of the end-of-life work and particularly the board. Thank you.
Thank you. Julie Lawn?
Hi, my name's Julie Lawn. I'm part of the Garforth Medical Centre PPG, and I was invited to come by Adam.
Thank you. Nancy?
Hi, my name is Nancy. I don't know. Can you hear me?
Yes. Yes.
Oh, okay. Because I'm not part of Microsoft Teams, so I don't have a video or anything like that. I'm a member of the public. I've lived in Leeds since 1970s. I'm kind of getting myself together for doing planning my own sort of wills and things of that nature. So as a resident of Leeds, I was interested to hear about end of life and how Leeds National Health is looking after that. So I'm kind of a curious member of the public.
Thank you. Well, that's what we want. So that's great. Adam Stewart?
Hi everyone, I'm Adam Stewart. I work with Chris in the involvement team at the ICB in West Yorkshire, in Leeds, sorry, and helping to try and embed patient involvement in all our decision making and all this sort of stuff. So lovely to see you all. And some of you know me because I pester you a lot.
Thank you. Now, Diane, I don't know if Diane's still on the phone. If I don't hear anything, I'll introduce her. Okay, Diane Boyne is the network manager for the Leeds Palliative Care Network and is a fount of knowledge on all the services that have gone on for many, many years. Now, have I missed anyone with my jumbling screen? I'm hoping I've gone through everyone.
I think Kath has just joined.
Oh, it's Kath just joined. Sorry, Kath, I've missed you.
Sorry about that. I've had real trouble joining. I'm going to blame Virgin. But hello, everybody.
Hello. Right, I'm going to hand back to Chris, who's going to run through what we're hoping to achieve today. Okay, so what I'm going to do is just ask people to go on to mute unless they've got a question so that we don't get any interruptions. And I'm going to share my screen now. We've got a presentation to work through. Okay. So just let me know if you can see that. Yes, we can. Yes, we can, Chris. Yes. Lovely. So yeah, so this is a public involvement workshop looking at end of life care. As Adam said earlier, we are recording this so that we can share it with other people. So we'll let you know where that's going to be when we put it on the website. Thank you very much, Jill, for just doing the introductions. It's quite nice to see a range of different people that are coming. We wanted to talk through the aims and objectives of the session today. There is quite a lot of stuff to get through, so we'll see how we get on. But for me, this is very much the first step in a journey of involving people in end-of-life care. So even if we don't get through everything today, that's not a problem. So the aim is to develop an approach to public involvement in the population board. So we want to make sure that all of our boards in Leeds have got that public involvement is an important part of each of those boards, and that's what we're looking at today. So the way that we're going to do that is we're going to talk very briefly about population health and the board. What is the role of the board? And we're going to
have a look through and hopefully agree the findings of the insight report. So that's some work that we've done around what are people's needs and preferences and experience of end-of-life care that we already know about. We're going to review and agree the draft outcomes for the board. So each of the boards in Leeds, which we'll explain a little bit more about that in a minute, but each of them has a number of outcomes, things that they want to achieve, things that we'll measure to know whether or not we've been successful in our work. So we're going to go through the draft outcomes for end of life. We're going to start thinking about how do we involve people and understand people's experience, where there are gaps in our knowledge around particular communities, whether that's gender or race, and how do we start to understand the needs of those particular communities. And probably most importantly, we're going to agree, how do we represent people at the board and provide assurance that we are listening to people, that we're acting on what people tell us, and that we are feeding back to people. So they're the objectives of the day. The outcomes. So at the end of the workshop, this is what we'll kind of measure, I suppose, in the evaluation. So by the end of the workshop, you should have a bit better understanding of the role of the board and population health. You'll have had a chance to discuss the findings of the insight report that we put together, and you'll be able to influence that insight report if you feel we've missed things. You'll also have an opportunity to talk about the gaps in our knowledge, the things that we know we don't know, and maybe you'll identify some other gaps that we haven't yet. There'll be an opportunity for you to discuss the draft outcomes and give your feedback on those. You'll have a chance to explore ways in which we can provide assurance that people's voices are heard at the board, and you'll be able to influence the approach to public representation and assurance on the board. So if we're successful with our session today, you will be able to tick all of those things off. So very quickly, the agenda, there are sort of 5 sections to this. The first one that Jill is going to go through is population health. What is the Population Health Board for end of life? What is it trying to do? Then I'll be talking a little bit about what we know about people's experience of end of life care in Leeds. What have people told us over the last sort of 3 or 4 years about using end of life services? And then I think Helen is going to talk a little bit about population outcomes. So what are the population outcomes for end of life care? Then myself and Kath will talk a little bit about public representation and public assurance. Don't be too worried if you don't understand what those terms mean. We will explain that. But basically, that is, what does public representation look like on the board? How do we make sure that we can demonstrate that we are listening to people when we're making our decisions? And then we'll briefly just go through what are the next steps for this piece of work. Like I said, this is the beginning of a journey, I suppose, about how we involve people in this work. I'm going to very quickly go through some ground rules, which I think are quite important. There's a lot to get through, so I'd like us to try to stick to the agenda. So if we do sort of veer off the agenda, I might gently move us back onto time. I'm very happy for people to be honest. In fact, I'd encourage people to be honest about how they feel about end of life. Be open to new ideas. Please listen to others and respect that some people, might share sort of personal experiences that they don't want sharing outside of this workshop. Don't judge people. But most importantly, just enjoy the session. If you've got any questions as you go through, we'll ask you to wait until the end of that particular section before you ask them, or you're very welcome to put them into the chat. So I'm just going to hand over now to Jill to talk a little bit about population health and the role of the board.
Thank you, Chris. So yes, I've been asked to talk about population health. I don't want to get too weighed down in this and just really kind of explain what the kind of fundamental difference is. So from that, we need to think historically how we used to kind of act as a kind of a healthcare service across Leeds. We used to kind of be individual organisations, very much working in our organisations with not much collaboration between different kind of, well, there was some, but not really working together. For me, population health is all about kind of having a population of people and then all the services which are involved with those people working collaboratively together to get the best outcomes for our specific population. So at the heart of it is the people and what we want to achieve for those people, as opposed to a kind of different kind of organisations all working for their best interests of the people, but not actually working together. Now, I'm sure academics out there who've worked on population health management will cry. I've just condensed all their work into such a small thing, but it is very much the people are at the heart of it, and we want to work together as a system across health, social, voluntary care, all the kind of systems working together in the best interest of those people. So, as I've said, it really focuses on putting the needs of the people and what's important to them at the heart of all decisions. Also, kind of value for money as well is really important there. Sorry, it's whizzed on to the next thing. The kind of to kind of explain, in Leeds, it's been organised into 9 separate population groups, going from healthy, people with long-term conditions, children, frailty, and the belief is you kind of just in one of those populations, but we understand that you may there are part of you that may be in different ones, but there may be one main focus. So we are obviously the end of life population that we're focusing on, and everyone involved with that is trying to work together collaboratively. I'm going to sound like Chris Whitty and say, can I have the next slide, please? So this is just a kind of just outlining the different population boards that we have across the city. And so each board is really responsible for improving the outcomes experience for the people in those cohorts, and also making sure that we have value for all the NHS money that we're spending for each population. As I said, the real stress is here, we're working across organisations, across different sectors, and very much focused on the needs of the people within that population. Next slide, please. So how these boards kind of set up is kind of agreed that we needed these boards to be broad enough to make sure that we're representing not just the clinical side, but also the voluntary sector. We've got the local authority as well. And so we have the different kind of members within these boards. So we have the hospital trust, the community healthcare teams as well, local authority, public health, third sector, general practice, the mental health trust. We have some clinical kind of specialist leads as well involved in there. For end of life, we obviously have the hospices represented, as they have a very important role as well. There's one area we've got here discussed as citizen rep. Now that's what we're not clear on at the moment, and we're hoping today we can really kind of focus on what's the best way to represent people and have them fully engaged in our board. The other kind of important part, it needs to be broad enough. We didn't want it to be kind of completely overwhelming, because we felt that too many people would lead to making it very difficult to actually make any decisions. It also needed to be senior enough so that actually people could actually make the decisions on part of who they're representing. Next slide, please. So just to kind of go through, there's a definition for end of life care, and if I just read that out, it helps us all to kind of focus what we're our population kind of engaged with. So it helps all those with advanced, progressive and incurable illness to live as well as possible until they die. It enables the supportive and palliative care needs of both patient and family to be identified and met through the last phase of life and into bereavement. It includes the management of pain and other symptoms and provision of psychological, social, spiritual and practical support. So it's very much the holistic kind of support of these patients. And it's the kind of, it's called the final, kind of the last phase of life. What we're thinking about here is not just those last few weeks and days of life, but that kind of extended kind of approach, kind of a year, even plus. It's different for different patients, it's different lengths of times, but it's being prepared as well as we can be for that last phase of life. Next slide, please. So these population boards, they're quite newly set up, and so it's kind of, we're all kind of learning what's kind of expected of us, but there are a lot of responsibilities which are going to be placed onto these boards, and there's agreeing the outcomes, what we all want to work to for our population to improve the outcomes for the people of Leeds. It's also looking at kind of where we have funding for our services and how we want to allocate those funding to best support the outcomes that we've all agreed. If there needs to be changes to services, we need to look at that and how best we can do that, and what our priorities are. With the constrained kind of financial situation the whole country's in at the moment, there are going to be difficult decisions that we will have to make. And again, linking to that is very much the kind of looking at the services we are providing, and do they provide value for money? So those are the kind of focus of it, and so that's why we want the kind of the workshop today to kind of really see how we can involve people in our decision making. And next slide. I think that's it. I think I'm handing over now. So I hope that made some sense. I think is it Chris. I can't remember who I'm handing over to now. Chris, sorry.
Yeah, handing over.
Or
to
any
me.
questions.
I guess I thought you did a great job there. It's really difficult to explain. It's complex. It's very complex, and it's quite difficult to explain in 10 minutes, which is why I gave it to you to do the presentation, obviously. I don't want to spend too much time on this, but I just wondered if there's any quick questions that people had so far before we sort of press on. I don't know if there's anything that's come up in the chat or anyone's got any questions. Anne? Oh, you're on mute, Anne.
Will the slides be available to download, or will we be able to access a booklet so we can take it back to our PPGs and any person that needs help?
Yeah, it's a good question. There will be a page on the website in the next week or two, and we'll be putting all the slides up on the website, but we'll also share the slides with you, and we've recorded the session and that will be on the website as well, so people can watch it back.
Thank you.
Great. I know there's a lot of information to take in there. You could spend hours and hours talking about population health and the boards. I guess that's not the point of this workshop. This is about how do we involve people in the board, so we don't want to get too distracted. So if there's no other questions, I will press on and I'll just share my screen again and go back to the presentation. Okay. Hopefully you can all see that. Shout out if you can't. So the next section really is talking about what do we already know about people's experience of using end-of-life services. So, and it's worth giving a bit of context. So in Leeds, we want to commission, and when we say commission, we're talking about planning and paying for services, and also to provide to care to people that's obviously safe, that's sustainable, so good value for money, and we can continue to provide that going forward, and that's patient-centered as well. We absolutely can't do that unless we understand what people's needs, preferences and experiences are like. And one of the things that we've committed to, not just in Leeds but across West Yorkshire, is to start with what we already know about people's experiences. In the past, we've kind of been guilty of engaging on every service change, and people say to us, you know, we've already told you what we think about this, why are you asking us again? So we're trying to get better at starting with what we already know about people's experience, and that's what we need to do for end-of-life care. So each of the boards in Leeds is working with its partners, so quite a lot of the third sector, but also our providers, to review all the information we already have about people's needs and preferences and experiences, and we call that an insight review. And all that information has been pulled together into what we call an insight report, and that insight report will be used by the board to understand the population and make decisions. It's pulling together everything we already know about people's needs, preferences and experiences. It highlights the key themes. So these are the things that come up again and again about people's experience of care. And it's also highlighting the gaps in our knowledge. So what do we know that we don't know? That might be around a particular area of end-of-life care, or it might be a particular community that we haven't heard from, but we know that are quite, you know, that are disadvantaged in some way. So that's what we are trying to do, is to pull together these insight reports. So the insight report has been written for end of life. It's a draft, They will always be drafts because we will always be adding new data and new findings to them. Once we've got the website up on, we will put the latest draft of the Insight report on there, and you'll be able to read it in detail, and we'll actually send it out to you all at the end of the meeting. But I just wanted to go through what we found, and we're going to get a chance to discuss whether or not you agree with these things. But from all the insight that we looked at, which was quite extensive, we found that people were generally satisfied with their experience of using end-of-life services and support. That people felt that people told us that patient-centred care was really important, and that the majority of people in Leeds were receiving kind and compassionate care. People at end of life and their carers value kind and compassionate staff, and the majority of people were very happy with the workforce. I mean, we hear this across everything that we do is the importance of kind and compassionate staff, and it sounded as though generally at end of life care that's what people were experiencing. People were saying that information about services, end of life services and support for people at end of life and their carers and family is sometimes poor and can be inconsistent. People told us that health and care services and support at the end of life was often not joined up. People weren't talking to each other, and that made the journey very difficult. People said that privacy and dignity was really important to them. People at end of life and their carers from diverse ethnic communities had views that were consistent with the wider population. So when we spoke to people from diverse ethnic communities, they were saying pretty much the same as everybody else. However, they did report having particular difficulties accessing an interpreter. In the health needs assessment in 2019, there was some variation in the experience and a need for improvement, especially among the following groups: diverse ethnic communities, people from areas of deprivation, so that's poorer areas, men and people under 65. So those particular groups tended to have worse outcomes, and that's a piece of work we need to do. And there were some potential gaps in our insight, and that was quite often that was around staff. What do staff think about services and how do they feel we could improve services? And also the needs of families and friends of people who die very suddenly, where there isn't a plan in place and when people die suddenly. So they were the kind of themes that came out in our insight. I'm going to just go through this slide, which is looking at the gaps in our insight, and then we're going to get a chance to talk a little bit about this. So the gaps for us were around ethnically diverse communities, in particular those communities where English isn't a first language. We didn't know enough about their experience of using end-of-life care, and that also links in with things that we've heard from Health Watch around sort of people's cultural needs, different communities having different cultural needs around end of life. I think that's an area we need to look at a bit more. There were some gaps around areas of deprivation. So what are people experiencing when they live in quite poor areas of Leeds? We heard less from men, and that's an area that we think we need to do some work around. People under 65 who were at end of life, we feel like that was probably an area we need to look at. And like I said, feedback from staff working with people at end of life is another area that might be a bit of a gap. Other gaps were sort of pointed out by particular community groups. So Carers Leeds gave us some really useful feedback. They were talking about inequalities in death, which links back to the ethnically diverse communities. Not everyone has the same experience. It shouldn't depend on where you come from. The needs of carers, families and friends of people who die relatively unexpectedly, are we meeting those needs? Practical support needs for people at end of life, particularly if they don't want to die at home. And then just some general concerns around how we talk about death and dying as a community. Obviously, it's a really difficult subject to talk about. How do we make it easier for people to talk about death and dying? So I'm going to move us into group work. We were thinking about going into smaller groups, but I think we might have a conversation as a bigger group. So I guess I want people to reflect on what we've talked about, the things that we found in these in the insight report, and ask themselves these questions. So, do you agree with the themes and the gaps? So, do you think we've got the right themes? Have we missed anything? Do you think we've got the right gaps? Are there any communities or areas that we think we probably need to know more about? And how do we prioritise and plan involvement work on the gaps? So obviously we've got limited resources. We can't just go out and speak to everybody. So where would you like to see us focus our involvement work going forward? So I'm going to stop sharing now and stop talking in a second. So, okay. So has anyone got any questions on what I said, or any thoughts about those things that we talked about?
I think Carl's put some questions in the chat, but sorry, you want to go to Liz first?
Oh, you're very quiet there. I don't know whether you think. Just say that again. Sorry, Rachel.
I think Rachel was saying, Chris, that there's
Can you hear me now?
that's come up in the chat.
Oh, okay. Let's have a look at the chat. Okay, hang on a second.
I think they're from Corsa. There's three there about
okay.
COVID and
How was care over COVID? Yeah. I don't know if anyone has any thoughts about that. I'm trying to think if there was anything in the insight report about care over COVID. I think that is something that may be a gap. Do we know anything about people's care over COVID? What people thought of that?
Diane, do you want to come in? I'm sure it's about the bereaved carers.
Hi everybody, sorry I wasn't free to introduce myself. I'm Diane Boyne, I'm the Leeds Palliative Care Network manager. So COVID, we've done two pieces of work through the Palliative Care Network that have given us quite a lot of insight into COVID. We're undertaking a big project to look at how we can improve care for people at end of life who choose to die at home or in the community, so in care homes and hospices, so out of hospital basically. And part of that was about Health Watch, speaking with the population and seeking a lot of feedback. We undertook this piece of work during COVID. It wasn't intended, it wasn't how we planned it, and it was quite challenging, but we were very successful in getting a lot of feedback. As you can imagine, we got an awful lot of feedback from people whose relative unfortunately was ill or died in a care home. So we did get quite a lot of variable feedback. We got feedback from people who said the care homes have been absolutely marvellous. They've put themselves out. They've done everything to try and protect them from COVID while still letting them visit their families and being with them at the end of life. But we also got a lot of feedback of people very frustrated at not being allowed to go and visit them. And I think the biggest factor during COVID for people, irrespective of where they died, was the inability of families to visit them and be with them at that difficult time. So we did get a lot of feedback about that. We did get some increased feedback around some dissatisfaction with the amount of care that people were receiving. And I think that was because the workforce was suffering with COVID at the same time as the population. So sometimes the number of nurses available to visit people wasn't as good as we would normally have hoped. The length of time that people could stay with people who were ill was not as great as it had been. And the virtual assessments and meetings that people were having on the phone or like this on video, some people thought it was really good because it made them feel safe and they could have a conversation while they were still at home, and other people felt that it was uncomfortable and wished they could have met somebody face to face. So we did get quite a lot of feedback during COVID. We also undertake an annual survey of people who tell us what their experience was of what observing and witnessing a family member who's died. And that's called the Leeds Bereaved Carers Survey. And we did get some feedback similar to what I've just explained to you through that as well. So yeah, we did get quite a bit of information about COVID. And as I say, I would say it's almost 50-50 about people's experience of whether it was really positive or some found it difficult. People with disabilities, we don't get as much feedback from people living with disabilities, although we are now working quite strongly with colleagues across learning disability services, so we're increasingly engaging with them, and we are increasingly getting input and feedback from them. And is the leaflet about end of life for people to know of the process? Is there a leaflet? That's a really good point, actually. There's a leaflet on our website, which is a patient information leaflet, which we're just about to withdraw, mainly because the services that are provided in Leeds are slightly changing, and some of the roles and titles have changed, but the information on it's quite useful. But it is exactly the sort of leaflet that we're looking to develop at the minute with all our partners. So I hope that's helpful for you.
Thanks, Diane. Liz, I can see you've got your hand up. I'm going to come to you in a second, but just to say that the disability one is something that Healthwatch have also brought up and said that they feel that that's maybe an area we need to be a little bit clearer about. What are people's experiences who have disabilities? So that's an area we'll look at a little bit more. And do we think that COVID, there's a theme around that needs to be picked up? Corsa, is that what you're saying?
Sorry, could you repeat that, please? Sorry.
Sorry, we talked a little bit about COVID. I guess, do we need to try to capture that somehow? And would that be a theme that people had a mixed experience of end-of-life care during COVID?
I think yes, and I think it's been exacerbated over COVID. And also, I know staff have been poorly as well, but there's not enough learning disability nurses, because lots of people, I don't know if any of you watched the panorama about people with disabilities and how, you know, the care wasn't as good because there's lack of disability nurses. Because my next question was going to be, how many disability nurses are there? You know, because from my experience, I've known quite a few people with disabilities who have died on their own and not even been told, you know, especially the ones that have no relatives, you know, for other people that worked with them, that, you know, they've died on their own. You know, someone could have sat with them. So it's sort of things like that I don't want people with disabilities to be overlooked. And I feel that disability, if there were more disability nurses, there'd be more care and compassion and understanding for people with disabilities. So that's, you know what, because I've got two brothers, and I worry, you know, what things might be for them if I'm not around, you know.
That's really helpful feedback, Corsa, and I will look into that a little bit outside of this meeting, and I'll try and capture that in the updated insight report. Liz, I know you still got your hand up, but I think Diane wants to just respond to that, so I'm just going to come back to Diane first.
I think that's a really good point, Corsa, and you're absolutely right. But one of the things I would say is we've recently started working with one of the senior managers at Leeds Partnership Foundation Trust, who manage a lot and have a lot of the learning disability nurses. And one of the things they probably haven't realised, because staff change and things change all the time, is that when somebody is approaching the end of life, they can access all of the other general nurses in the community. And sometimes the learning disability nurses weren't as fully aware of that, and often were only doing it at the very, very end when it was probably really difficult for them to know what to do. So we are trying to increasingly encourage the learning disability nurses to work with the general nurses in the hospices and in the community and the neighbourhoods, so that they get the general nurses involved, so they can give them additional support and advice, and if necessary visit as well, to help them with the end of life. But it is a really good point, and I think that the lack of nurses is a real challenge for everybody at the minute.
Yeah, I was just going to ask you, Diane, while we are talking about learning disability nurses, how many are there within Leeds, please?
I wouldn't have a clue. It's not my area of specialism. It is
a
good question, and we would be able to find out. But what they tend to do is also provide a lot of care through agencies and care assistants, don't they?
Well, we'll pick that up outside of the meeting, because it sounds like we don't have the answer to that. But Rachel, if you could just make a note of that, and we'll get back to Corsa about that. I think you've highlighted a really important point, and that may well be one of the gaps in our understanding is around learning disabilities and end of life, and that might be a specific piece of work we want to do to understand what people's experience is like and how we can improve care in that area. So thanks for that's really useful. Liz, I'm going to come to you. Thank you for being patient.
That's okay, no problem. Can I add on to the disabilities and the mental health issue as well? Because a lot of people, I'm not talking about learning disabilities now, but I'm talking about people with long-term mental health issues like bipolar disorder, schizophrenia, personality disorders and things like that, some of whom were put under tremendous pressure by lockdown, etc., and suffered greatly and increased the number of suicide attempts. I know one or two people in that category from my work as volunteer and also from friends. But the issues that I particularly wanted to raise were on the gaps. Have you covered travellers? I used to work at Pudsey DHSS, as it then was, and we were responsible for one of the travellers' sites. And I know that they suffered tremendously. And I know from Touchstone they suffer tremendously still. If they have mental health problems or anything of that sort. So I am concerned about the travellers.
Diane, did you want to come back on that?
Liz, just to let you know, so I think it is a point for consultation and engagement with that population, the travellers. There is a service that is delivered through Wheatfields Hospice to travellers, and some of their staff there work directly with the travelling population. So they do work with gypsies and travellers. There is also a specialist service run by Leeds Community Healthcare Trust, which they work very strongly alongside the Wheatfield service. So there are staff working with this population, especially at end of life. The extent to which the feedback from that population is being included in the insight work is probably a good thing to note, that it probably hasn't, and there probably is an opportunity for further conversation with some of those providers and the population. Thank you.
Thanks, Liz. I think this is really, I don't know about you, Jill, but I think this is a really useful conversation because it makes me think a lot about how does this board link in with, you know, that there is a board that's specifically looking at mental health. So how are these going to cross over? And there's also a board that looks at learning disabilities course as well, and neurodiversity. So how are these boards sort of talking to each other and sharing insights? So that's going to be a challenge for us going forward, Jill. I don't know if you've got a thought on that.
No, I was thinking exactly the same as these kind of issues were coming up, that it is that kind of, we need to make sure that we're working together with boards as well on these overlapping areas, definitely to support one another.
Yeah. Just so you know, Chris, the Palliative Care Network have a Equality, Diversity and Inclusion group where partners from all of these different providers do come together collaboratively. So we do, it's only fairly new, and we are starting to increasingly talk to each other and provide support across all of these different populations. But I think that there is an opportunity to increase our knowledge.
That's really encouraging, because what we don't want to do is go out and do a specific piece of work with travellers around end of life and then go out and do a piece of work around learning. You know, if we're going to do that work, it's about developing a relationship with that community, isn't it? And really understanding how all of these complex issues sort of intertwine. And so that's really helpful feedback. Thank you. Anne?
Yes, my daughter works for the university. She's part of the main group for mental health and serious illnesses with the Fairground Association, and the Showman's Guild are very, very supportive of mental health and serious illness amongst the health of the actual travelling showman, and also when they're in winter things. It's including the diversity and inclusion part of the university. But the Showman's Guild are very, very keen for people to help them, because there's quite a lot of mental health. It was always classed as a healthy lifestyle because you're travelling around the country and you're in the open air and everything else. It's obviously in later years it's not working that way.
Yeah.
So if anyone would like it is Leeds Beckett that are doing it, and it's the diversity, and as Diane said, it's quite a big group that are working on the mental health and serious illness.
That's great. Thanks, Anne. Julie, I'll come to you, and then I'll sort of move us on to the next section. You're on mute, Julie.
Okay. With regard to the practical side of the equipment being delivered and taken away again afterwards, when I've spoken to people who have had this experience, the carers, you know, of the people who have passed away, they've said how wonderful it was that all the equipment had been delivered so quickly, everything that they needed, and it was done on a personal level to what that person needed. But they've all commented on how long it takes to get that equipment taken away. So if there's a big bed in a room and there's going to be a funeral and they need people to have somewhere to stay, they can't because the bed's in the way or the equipment, you know. But they're all extremely grateful to everything that's happened before the passing away. But afterwards, it's very difficult because they just want it to go as quickly as possible, and it's not always that way.
Yeah, it's an awful memory, isn't it? Because it's just a constant reminder if that equipment's still there. I don't know if anyone has a response to that. I could see Diane nodding in a kind of knowing way.
Yes, it's not a new story, that, unfortunately. When the pressure's on in the system, the pressure's on to get the equipment to people who need it, and the same vans are really busy doing delivery, and they don't always have enough lorries to go out and collect the equipment, which is a bit counterintuitive because basically they return it, clean it, and make it fit for the next person to use. But yeah, we do have a relationship with Leeds City Council who deliver the equipment service, but it would be a very good thing to feedback from this group just to reinforce, because it's a message that keeps popping up on and off over the years.
Yeah, and I think it's about how do we manage some of these themes that are coming through on the board, and it might be that we have some dedicated time to sort of review these and see, has there been an improvement, how have those things changed. But it's really useful feedback, Julian. We will capture that and put that in the
City
report.
Council colleagues that we need to engage with for that.
Yeah. Corsi, you got I'll come to you, and then I think Adam's got his hand up, and then I will try and move us on because we are running out of time a bit.
Yeah, I just want to add on to what Julie just said. My mother-in-law passed away in hospital, but for me, what it is that, you know, the nurses were amazing. They treated my mother-in-law with respect. My issue is for the hospital actually release my mother-in-law's body took too long. It took too long, and especially with the Muslims. You know, we have to organise a funeral on the same day kind of thing. So for me, that was very frustrating. And also, she still had the cannula in, and I, from my experience, I've had another Muslim person who had something stuck in their leg, and we didn't see that until we came to bathe them, and we couldn't remove those items. So those are the sort of things I would like an answer to. You know, what is the process? And because I was naive to that, it's only when, you know, I got my mother-in-law and we were about to bathe her eventually, I found these things on her and I couldn't remove them because it's, again, as a Muslim, it's the pain that we're giving the person that's passed away. So it's those sort of questions that I would like answers to, or could you pass me on to where, you know, as Muslims, we can be aware. That's why when I talk about a leaflet, those sort of information should be there so we are well prepared to know what to do with our loved ones and how quickly we can go through the process to get the body released, you know. So, you know, the time is of essence.
Of course, can I just ask how long ago that was? When your mother-in-law died?
She died of COVID.
Oh, so quite recently.
Yeah, very recent,
okay.
Yeah.
It's just I know that the bereavement office have been trying really hard at the hospital to try and improve this exact issue. It was at one of the hospitals, was it?
It was LGI.
Okay.
No, but I had to sit outside the office to keep reminding staff, look, I am waiting. Can you hurry up? Can you hurry up? And you know, when you're bereaved, you're upset. It's not the right place to be putting that stress on the staff. You know, staff should be aware that this is a Muslim person that's passed away. Can we get on as quickly as we can? Because for them and for myself, because I wasn't happy doing what I did, but that's how it went.
And I think that this really highlights the need to do a bit more work with that particular community to understand what their needs are. And it does sound like some sort of a leaflet that explains, you know, how things work in the process and things might be a useful thing to look into. Obviously, there's we'll have to prioritise and decide which we think is the most important thing to do, but that's really useful feedback. Adam?
I'll be quick, I promise. Oh, I'll try anyway. People know me, those I'm not particularly quick. It was just, I think this conversation has been fascinating and really interesting, and thank you everyone for sharing your feedback. And I was thinking about the mental health element and Liz's point about people who've died by suicide or how to increase suicide attempts. They are not dying well, they are not dying with dignity, and it just made me think that there's that crossover about the mental health element to it all, the population board there, and how that kind of ties in with end of life. And I know that people have said that when they come in to emergency services or urgent services, when they have had a crisis or a suicide attempt, that the potential treatment is potentially a bit more stigmatized, or the attitude hasn't been particularly great and stuff like that. So I think there's something about how is that joining up. And it was just a reflection. I don't necessarily know there's an answer or what the work needs to be done. It was just it was very interesting, and it made me think about that. And I work with the mental health board, so I will be certainly learning about that and taking that on board as well, thinking about that.
Yeah, it's just a really useful conversation to have, isn't it? And an important reminder about how much these boards are going to cross over and need to be talking to each other. I'm going to move us on. I'm just going to share my screen again. Look. Okay, so I'm hoping that you can all see that. Shout out if you can't. I'm just going to pass on now to Helen, who's going to talk a little bit about population outcomes, if that's okay.
That's great. Thank you, Chris, and thanks all for your input so far. It's really valuable. In my section, I'm going to talk about population outcomes, and I know we've touched on this throughout the morning, and you probably had information about it previously, but just as a bit of a recap, when we talk about population outcomes, what we're really saying is that we've come up with an agreed set of statements that says, if we get healthcare delivery right, and if we commission and plan services right, what will that ultimately mean for that individual, and what kind of healthcare and outcome could they expect to receive if we're doing everything the way it should be done? And that's really what we mean by an outcome. So we've been working on developing these over at least the last year with partners to agree our set of outcomes based on end-of-life care in Leeds, and all of those other population groups that we talked about also have a set of outcomes. So we've all been doing this work at the same time. And the outcomes really explain what we want to achieve to improve the lives of people, but also their carers, family and friends. So it does extend beyond just the individual. It has been a little bit of a journey, because we also have an end-of-life care strategy, end-of-life palliative and care strategy that was developed, that also included a set of outcomes. So we weren't starting from scratch. We've built upon previous work. We've grown the measures that we use to measure the outcomes. So it's been an iterative piece of work that's been evolving, and along that journey we have tried to include and develop those outcomes with service providers, voluntary sector organisations, people that represent that are represented using end-of-life services, and they have been shaped and used by patients, carers, family, staff feedback, services, carer surveys, involvement activities. So it has been as inclusive as we've been able to make it so far. We've had Health Watch quite involved as well. I think it's probably fair to say, though, that we've reached a stage where we do have an agreed set of outcomes, but they're not static. And it doesn't mean that they won't evolve over time, or that we might look at review them and refresh them as time goes on. I think it's really important that we're not held and fixed to something at a point in time if the needs of that population changes. So more than happy to receive continual feedback. Next slide, please. So these are the outcomes, and again we sort of say draft in the same way that Chris said draft on the insight report, because I think there's something about continually evolving. So what we've agreed with the partners that have been involved so far is that people approaching the end of their life are recognised and supported on time, and I think, you know, something about that is time is of the issue. And people approach the end of life live and die well according to what matters to them. So we really take on board their needs, and that we deliver care based on what they want. and that all people approaching the end of life will receive high quality, well coordinated care, both at the right place, the right time, and with the right people. And that people approaching the end of life and their carers are able to talk about death with those close to them in their communities, and that they feel their loved ones are well supported during and after their care. So we feel as though we've got quite a broad but useful set of statements there. And if we actually work with the outcome in terms of the delivery point and what we hope to achieve for everybody in Leeds, we can start and work back from that and say, well, what are the steps we need to put in place to allow us to achieve those? And that's really the work of the board now going forward. Next slide, please. So for each set of outcomes, and I'm conscious that this is quite small print, so I'm not expecting you to be able to delve into this, but we will be sharing this afterwards, so you will be able to delve into the detail. But it was just to show you that on the left-hand column there, we have the outcomes that I've just mentioned, the 4 statements. We have a set of outcome measures, and for some of those, we have a process measure. The difference between those, I don't wish to sort of bog down in the detail, is that some measures are an indication of how well we're doing along the journey, but wouldn't necessarily tell us whether we'd achieve that outcome. So, for example, people approaching the end of their life are recognised and supported on time. We have a process measure there that says we will measure the percentage of people on the end of life register with a preferred place of death. But if that's all we measure, it wouldn't tell us whether then people were actually supported in their choice of place of death. So that's why sometimes we have to build in additional measures. And I won't go through all of those because, like I say, you will be able to look at the detail outside the meeting. But just to say that there is quite a set of data that sits behind this, that as people working in the system and planning services in the system, it's our indication of how well we're doing. That the end point is actually for the individual and for the person to receive their care based on what we said in the way that they should be able to receive it. The measure for us is saying, are we getting it right? And for us to be able to monitor and flex services that would enable us to get it right. So hopefully that just provides a bit of a background as to how we're measuring and working to achieving those. Next slide, please. So that was a really quick run through of the outcomes. So just a few questions, an opportunity to feedback on those. Do you understand these? Do they make sense to you? Do they reflect, do you think, how we should be delivering care? How would you like us to demonstrate improvements against these outcomes? Is there anything we might have missed there? And how do we involve you going forward? So happy to open it up to questions.
Okay, thank you for that. That's really helpful. So yeah, so just to reiterate, I guess we want people's reflections on those outcomes. Do they make sense to you? Do you think that if we achieve those outcomes, do you think that that means that we're providing good care? I'll start with John. I think John had his hand up first.
You thought you were going to get away with me not saying anything in a meeting.
No, I never did that.
Yeah, the area I want to pick up, it's good to see that carers are included there, because if we're not careful, we end up with carers becoming people needing care. And 2 things come to mind, well, two things are driving the concerns I've got. One is about supporting, well, my experience of supporting someone. Now, I've got a professional background. I'm pretty good at persuading people and so, but I found it difficult to engage with services. Now, I'm not at end of life here, but we're starting to get to that stage. But also, I now find myself supporting a few people who have someone at an end of life stage, and they really are very stressed about non-medical issues, so how do we organize a will, how do we pay for the funeral, how do we do a whole load of range of things. Now generally I'm talking to them and then also pointing them towards Carers Leeds or Age UK, the 2 main sources, but I think we need to maybe have a look at what more do we need on perhaps a non-clinical but but factors that have a major impact on possibly the patient themselves, but also certainly on the carers, and see whether we need to be doing that. I mean, we picked up a few years ago on social prescribing, recognising that that's a major impact on people's well-being. And we do have other activities going on, and I just would like some assurance that we are looking at carers, unpaid carers experience, and what we can maybe do to engage with, whether it's the third sector or how we do about it, but people who can just facilitate things and say, right, this is what we need to do to register a death, this is what we need to do to plan ahead, is it worth thinking about a lasting power of attorney, what does all this mean? So just a contact really, where you can say, what do I do here, what's this, I don't know what I'm doing. And I would hope we will find time to investigate what the demand is and what the need is, and to what extent we can help meet that.
Thanks for that, John. So I think what you're saying is that there are a few concerns that the outcomes don't sort of capture that practical need for support that carers have at end of life.
That's about right, Chris. Yes, the phrase is there. The stuff is there saying you've got to think about carers, but that's maybe a non-medical, a non-clinical side that has a major impact, and we need to look at how can we, even if it's commissioning another body to do the work, but to have that helping hand there to help you through the stuff that is nothing to do with the actual hands-on care.
Thanks, John. I don't know if anyone's got a response to that, or whether that's something we just want to go away and reflect on as a board.
I'm happy to take that away and reflect on that as a board, Chris. I was just having a look down the population outcomes just to remind myself how much that is captured. And I know it's certainly been part of conversations that I've been involved in. But yes, happy to take that away. Thank you.
Thank you. Kerry, was it a response to that, Kerry, or you had?
Yes, it was. Yeah, thanks, Chris. I mean, it's to say I think it's a really, really good point, and I think I think as you say, you know, John, you referenced Age UK and Carers Leeds, and I think if people are under the care of the hospices, they get a lot of that information, the different information in Leeds Community Healthcare, LTH. I think there's maybe that's part of the problem. I mean, one of the things that's come up in feedback from patients and families is about how integrated the system is, and what you're talking about here is some of the really practical elements of providing holistic care that need to be built into an integrated system. So I think maybe it's both establishing what we have and how we better integrate that and clarify it for people so that they can access it wherever they come into the system.
If I can just add as well, another factor to keep in mind is that probably most of us here are quite articulate, quite determined, are able to look at, you know, what the process should be, and are able to push forward and argue for resources, but an awful lot of carers aren't. And therefore,
totally right.
they maybe will go in guns blazing, where that might not be the most effective way to do it. And that's just due to pure frustration. And quite a lot of my time with talking to people is trying to say, look, how about doing it this way? Yeah. You know, like I ended up having to do with ASC, which was saying, look, I totally understand all the pressures. And I said, I'm sorry to have to do this, but I'm going to have to put the screws on a little bit, because otherwise you will end up with a major scandal on an individual who's likely to be dead. And it's supporting people in that communication as well. So yes, it's right across the board. It's how to deal with the non-medical, support people in accessing and facilitating for them if necessary, getting to the non-medical, non-clinical factors that need to be dealt with.
Really helpful, thanks, John. We will take that away and think about what we do with that. And I can see you got your hand up, but I'm going to go to Kath first, because I think Kath was there first.
I just wanted to ask that whether or not we're looking and measuring about people who want to have an end of life in one way, but then it doesn't work out. For whatever reason in the family, that say, for example, they can't die at home. One of the things that came out from the Insight report, one of the small negatives, was about a lack of communication, a sort of a joined up communication. Are we going to measure or look at how when that happens, somebody changes their mind, may wanted to die at home, but say, for example, wants to go in hospice. Have we got the procedures in place that make that a smooth process and less upsetting for the family and the person who's at the end of their life?
Yeah, it was an interesting conversation, that, Kath, about how, you know, people have this idealistic view. They want to die at home. It feels like it's the right place, the most peaceful place. But then when it comes to the final days and hours of life, it changes, and people change their mind. I'm not quite sure how that works with end of life care and what we've got in place for that. Has anyone got a response for that? Diane? You're on mute, Diane.
Hi, Kath. Yeah, I think the answer to that is we do some of that. We do record that. We can report that. We would like to improve the information that we gather, and we'd like to improve the amount we can report. We are very conscious that people sometimes change their mind reasonably, or because their health condition is different to what they might have expected. It is a challenge because it's about making sure the information we gather at that crucial time is changed on the system that reports it for us. So we do gather the information, and we can tell how many people would have preferred to die at home but died in hospital, for example. So we do report that on a quarterly basis. We do have quite a lot of work with partners collaboratively to improve transfer. The truth is, though, choice is limited by what choice is available at that time. And so that has to be a genuine and I think honest conversation with people at the time is, you know, what you would maybe want, is it available? So like a hospice bed can not necessarily always be guaranteed for that person at that time. But the partners do work quite collaboratively to try and make sure that people are placed and enabled to go where they would prefer, if at all possible. We do try to gather the data, but we could do better, I suppose, is the answer.
With some of these things as well, I guess it's an opportunity to test whether or not some of these experiences that are coming out are commonplace or kind of a one-off experiences, and they're the kind of things that we can use some of this feedback to shape the bereavement survey, so that we can ask some of these questions specifically to a number of people and say, is this something that's happening regularly, or is it a kind of a one-off event that needs picking up as a complaint or as an individual issue? So it's all really useful feedback. And I'm going to come to you. Thank you for being patient.
Sorry, was that for me?
Yeah, sorry, yeah, I'm here with...
Sorry, I thought there was someone before me. My question is for the outcomes. You know, like you could have on your notes, do not resuscitate. But what if towards when you know situations change and you change your mind? Is that something that people should be, when you actually put that in place, should be well aware of? If towards the end you know, when you become safe, you want to change it. Can you do that, or what is the process, or somewhere along the line it needs to be clear to the person that once you do that, there's no going back, even towards the end, that when you change your mind, you know, it's, I don't know how to explain this, but I know that a friend of mine had that put in, but when it came, you know, became really ill, this is, I don't want this, I want it taken off, but it was too late. So I mean, if you're going through the process of dying, but you've got this, you know, stress of, oh, I don't want to have that on my record. You know, I don't want to die. I want people to help me. Can you do that towards the end? I mean, is there an answer? Could you give me an answer as to the process of do not resuscitate? Can you change it?
And you're on mute. Sorry, Diane, you're on mute.
Yes, you can change your mind. Yeah. Jill Pottinger probably could answer it better, but yes, you can change your mind at any point, at any time, and change what's being recorded on your records.
Yeah, but Diane, from my experience, I found that the only person that could change it for is a doctor. You know, so if you decide at that moment, I don't want it on, you have to go through a process to have that taken off, and that could take hours, couple of hours, 3 hours, I don't know, but it can't be immediate. You know, you can't just verbally say it and then it gets changed. It has to go through a
True.
process, and that's the part
True.
that is stressful for the person that's dying, if you see what I mean.
This is, I mean, it's a very specific issue where I don't want to get too caught up on one specific issue, but it does bring me back to the question that someone brought up about having information about end of life care and what you can expect, you know, common questions that people might ask like that around resuscitation, so that we are at least very clear about what we can offer and what we can't. I'm going to move us on because I'm looking at time, and I am definitely coming to you, Anne, this time.
Right, can you hear me?
Yes.
Lovely. Mine's just a comment, and I was interested, although I couldn't read it very well, the chart showing the sort of how measuring the success of the outcomes, and it's just a comment that very often in businesses generally, you can have these as a nice ticking exercise, you know, ticking the box, and that what I'm hoping is that those issues or those outcomes that can be measured are measured properly, and that they are reviewed, and some of them are SMART targets to work towards, and and that they're reviewed regularly. So if the boards are not meeting their targets, that some recourse is there to actually review again and set a SMART target again, so it doesn't get lost down the line. That's the only comment I wanted to make.
And I think that's the point of having this workshop. It's the start of a journey about involving people in that, and I think it's about us working with the board and holding the board to account for all these outcomes and saying, can you demonstrate this? You know, and I think that's the part, it's the beginning of that journey, really, about being involved in that process.
Thank you.
Okay, so I was going to ask if people feel comfortable with the outcomes, but I feel as though people probably need a little bit more time to digest them and have a look through them. So what we'll do is we'll send out some information afterwards, but one of the things we would like to know is, do you feel that these outcomes are accurate? Do you think they reflect what you would expect as an outcome for someone at end of life and their carers? So we'll send something out after the meeting for you to fill in and let us know what you think about that. Give you a bit more time to read it through. I'm going to move us on to the next section. I'm going to share my slides again. Can people see those?
Yes, we can.
Okay, that's great. Thank you, Anne. Okay, so I'm just going to move us on to probably the most important bit of the workshop, really, and that's about public representation and assurance. So I'll try and explain a little bit about what we mean by that. So as a partnership across Leeds, we've got a legal duty and a moral duty to involve people in the decisions we make. We can't make these decisions without involving people. It's really, really important. We want patients, carers and the public to be assured that we are putting people at the heart of decision making, and we call that approach public assurance. I think that for people to feel assured that we are listening to them and acting on them, these are the three things that we need to do as a board. We need to listen, so we need to demonstrate that we've listened to people, and that will be using things like showing that we're using existing insight, carrying out involvement activities to find out when there's gaps in our knowledge. We need to demonstrate that we've acted on that feedback, so we're actually using that feedback and those experiences of people, we're using those to shape services and plans. And we need to feed back to people to clearly demonstrate how we have used that feedback to shape things. It's not good enough for us just to say, well, we have acted on it. We need to show people that we have. And I think that if we are listening and we're acting and we are feeding back, it means that we're transparent and accountable, and it means that we're providing assurance that we are putting patients at the heart of our decision making, and it is meaningful. So one of the things that we're doing is thinking about how do we provide assurance and have public representation in the end of life board. I think there's lots of ways that we provide assurance, so I'm hoping that you will go away from this workshop feeling assured that that we have done our insight work and we do have a good understanding of what people's needs and preferences are. But we want to continue and build on that work. And I guess one of the things that we've talked about as boards is having a citizen representative to sit on the board, so to have a place, an actual voting place at that table. If I'm honest, I'm not convinced that that's the right approach. I think that's a lot of pressure to put on one person to represent the whole population. So, but I guess what we want to do is have that discussion with you today to talk about, you know, how would you like to see people at end of life, their carers, their friends, their families, how would you like to see them represented at the board? And how would you like to see us provide assurance that we are listening to people, that we are acting on what they're telling us and that we're feeding back to people? I hope I've explained that well, because it's quite a difficult thing to explain in such a short space of time. I guess this is an opportunity now to start to have a conversation about that. So it'd be really useful to get your reflections on what do you think of the ways that we're already involving people, so our insight work and like this workshop. What does public representation look like for you, and what would make you feel confident that we are listening to people, acting on what they're telling us and using it to shape services and feeding back to people about the difference it's made? So I'm going to stop sharing now. And bring us back. So I can see we've already got some hands up. I don't know who went up first, but I'm going to go for Liz.
Thanks. Yeah, a couple of thoughts really. One is that workshops are a very good way to get feedback if you can encourage people to come to them. I mean, I'm conscious that there aren't that many of us strictly ordinary public people who have no sort of academic involvement at this one here. Now, I mean, I joined simply because I got the information, so I thought that sounds good. I'll go to that. So we need to find a way of encouraging more people to get involved with workshops. I don't think electing a single civilian representative will work at all. I think it will not only put pressure on that person, it will end up with them being blamed for decisions by the rest of the public, and will cause conflict between different groups of the community who feel that their needs are not being represented by the person who's being chosen. So I'd be very much against having a single civilian representative. I think questionnaires, workshops, direct interviewing of people is the only way we can actually get the information that we need. And we can involve all sorts of bodies in that, community centres and all sorts.
Thanks, Liz, that's really helpful. I think it's important to talk about the difference between experience and assurance. So I think that there are lots of ways we need to be capturing people's experience of using services. So Diane will tell you about the bereavement survey that we do every year. We can do additional bits of involvement. There's lots and lots of work going on around the city to understand the needs of people at end of life and their carers, and that all that insight needs to be brought together. But I suppose what we're talking about here is an assurance body to feel assured that the board is actually listening to all that feedback. And
which is why I concentrated on not electing one person.
I agree. So what I think you're absolutely right. It puts a huge amount of pressure, and also there's risks around that whereby people could promote their own interests there. Yes. How do you feel assured that they are talking on behalf of the whole community? You know, we've got a very diverse community in Leeds. We can't, if it's one person, how can they possibly do that? I guess my question next to you, Liz, is what's the alternative?
Oof. Smaller working groups submitting reports. That's one way forward. They could be volunteers, they could be drawn by suggestion from the carers, for instance, and other bodies. The bereavement people could put names forward of people who are willing and able to talk and come and express an opinion on how satisfied they are with what's being done and whether we've achieved what we've set out to do. And if you have a small group, you're more likely to get some feedback. If you have too many, as you said earlier, what happens is that some people don't say anything at all and other people talk too much, like me.
Thanks, Liz. Corsa, let me come to you. What are your thoughts?
My thoughts are like, you know, it's all right having these smaller groups, but when you're actually going through it, you know, it's all still fresh, isn't it? So I think there should be a system of being able to give feedback straight away, whether it's positive or negative, and that being collected, you know, from hospital, from homes, whatever, you know, because I mean, you get that for when you go for appointments and stuff, you get a text back saying, how did you experience that? Could, you know, something along those lines that you're able to collect afterwards. So that's what I'd you know, I think.
Yeah, I think that is really important, that real-time feedback, and it's particularly with this board, it's a really difficult thing to talk about. It's a very emotive subject for people. I guess my question, Corsa, is who holds the board accountable for their involvement work, for involving people? How does that work?
Oh, I don't I don't know, but I know that getting that information back for people to make, I mean, we have pals, don't we? But not everybody knows how pals work, you know, for positive and negative feedback. But there should be some kind of system where all this information is put in for you to be able to get it, you know, like you say, real time. I don't know, but I do feel it's important that you get it, capture it there and then, you know, by even if it is by a text or something, that everyone who's involved with that bereavement has something to say, or their PAs or whoever, that you get it straight away. And then I don't know. I mean, you have I mean, I'm a carer, so my brother's day services have a CQC, and they sometimes ring me and ask me what my experiences are of that service, and maybe, you know, from the feedback you get, you randomly pick a person and ask them for collecting your data or whatever. I don't know.
What we'll do is I'll have a look at how we cook. I know we do annual surveys, and I think we have very different ways of collecting that patient experience, which I agree is really unhelpful. It doesn't go into one place. It goes all out, you know, each organisation has its own. So I think that's how we collect data and how we share it with each other and use it to influence the decisions we make, I think is something that we need to continue looking at. So thank you for that. John?
A couple of weeks back, I was a speaker at a session on family and patient support with the HSJ Congress, and I had a minute of kind of sudden enlightenment, really. And I won't go into this in detail, Chris, because you and Adam and Kath and Animus have all had these debates, but we had two groups in this presentation. There was one from NHS England, and there was our little team from Leeds Teaching Hospitals. And it was quite clear we were looking at two different things, but it dawned on me that actually really both crucial. So one was pretty much what we've been talking about here, is talking directly to individual patients and carers. The other one was what we've been doing with Leeds CCG for a while. I've been doing with Leeds Teaching Hospitals and with the ICB at West Yorkshire level, is being a representative. And I slightly disagree. I think there is a role for an individual to be part of a board. And it's not there, as you said yourself, Chris, it's about assuring that the viewpoints are taken into account, to be a critical friend, to say, that's good, But how about we could make it better if we took these in a factor as well? So I mean, a lot of what I do is in challenging issues about digital exclusion and making sure that we've got channels of communication and that we do inform people. So I think there is a role for an individual, but as we found out, and as LTHT have found out, you need to invest in that team of people. So we had the lead CCG volunteers, we have the quality improvement and patient safety partners in LTHT, and they get the support, but they are able to be there because we need someone there at the board, because if things are starting to go a little bit awry or that not all the facts have been taken into account, we really need to deal with it there and then in that board. So I think there's a role for both. I think there's capturing the individual. I mean, in fact, if we get technical about it, it's a patient public voice partner role too, which we need, and that's what we've talked about here. But we also need the role 3 and role 4. And just as a wee aside, I mean, I know, Chris, you and Adam and probably various other people have seen the wee thing that I throw around a lot about the 6 key advantages of this role 3, role 4, about the things we bring, what we help, how we help the organisation. And I'm happy for that to be shared out if you think it would be useful to give people a different perspective. But we need both. We need to be talking to the individuals who are affected, whether we do that always directly, whether we do it via partner groups, sector, etc. But I think we do need this person who's got a long-term relationship with the organisation, understands what the organisation is about, what their drivers and what their ambitions, what their constraints are, but is still there to be able to challenge as a critical friend, saying, I think we can do this better. Let's see, how about if?
Yeah. Okay, take that on board. I guess if we do decide that we think the best thing to do is to recruit someone to that role, we'd need to think about how do we recruit them, who's the best person, what support do they need in that role. So it would open up a lot of questions, but I think it's, we're very open to the approach that we take, and that's really useful feedback. Let me come to you.
So if it's any use, we're just starting to do the same for the 3rd tranche of quality improvement partners in LTHT, and yeah, it does require investment, but I think we as an organisation benefit from it.
Thanks, John. Anne, let me come to you.
Hi, just a couple of things. I think the workshops are quite a good idea, and maybe I think Liz mentioned it slightly. The timings are an issue, perhaps, to get a better cross section of people and their view. And I know that's hard when people like yourselves work what I call a daytime role, but maybe there is a need to perhaps offer some access to a workshop in an evening. I'm fortunate, I'm retired, and therefore, around my social life, yes, I can access. So that's just one thought, maybe. And
can I just come back on that, Anne?
Yeah.
I think you're absolutely right. I completely agree. And it is something that we have thought about. We've had some really great support from Rachel, who's on the call. She's been supporting our work, and that team are supporting us to run these workshops for all the other boards. And one of the things that we've asked is, can we look at running these on an evening or a weekend, and kind of varying it so we can attract people who are working during the day. So it's really useful feedback, that, Anne, and yeah, we're on that.
Yeah, excellent. And I do think that those workshops would give you a collective feedback that then the right people can take to the board. But I do agree with John. I do think there needs to be some representation there, so that someone, and that is a big responsibility. So maybe the way forward is to have a little group of people who actually could volunteer, because not everyone can attend. They've got a life. But if you've got a group of people that you could call on and ask one of them, are they available to attend? That at least means that with a bit of luck, all meetings are attended by somebody to represent.
So can I just clarify that, Anne? So what you're saying is that there would be a small sort of group of people who have an interest in end of life, who meet up regularly, and one of those people would attend the board to represent that group and represent the public.
Yes, and one that could actually make the meeting, so that there isn't a meeting goes by where there isn't representation. Yeah. And to try and take away some of the onus of the responsibility of that job, and to stop it becoming very personal from that person. I don't know whether there's any voting goes on in these boards, but maybe it could be a non-voting position where you're there to represent and to feedback. But so non-voting is an option. I don't know. That's all I would say. Yeah.
Really useful. We honestly don't have a preference. Really, that's the whole point of having this workshop, is talking about what are the options, what's the best, because it has to be something that is practically going to work, because there are some risks. Obviously, if it's a different person going to the board each week, that might make things a bit difficult with the consistency and continuity. So we have to find a practical way. And also there's training that's required as well, and additional support. We need that person to feel comfortable in that role, to know what they're doing and feel they've got the support. So this is very much an early conversation about what that might look like. Julie, I don't want to put you on the spot, but I'd just be really interested, if you've been managing to listen into that conversation, what your thoughts are. You're on mute, Julie. You did come off mute for a second. You're off mute now, I think.
I did click on it and it didn't work. I have been listening, but I don't really have any feedback on this one.
That's fine. It's a tricky one, I think, and it might be that people go away and reflect on it and want to share what they feel. When we send out the survey afterwards. So we're not making any decisions today. We're just sort of starting that discussion. Liz, you've got your hand up.
Yep. Sorry, can I just finish?
Sorry, Julie. Sorry.
It's okay. I just think I wouldn't want just one representative on the board or whatever. But I'm not sure it's quite detailed in the answer to what you do instead. So I won't go into it really now, but the reason I'm coming in and out of screen is because I've got a cough, so sorry about that. I do apologise.
Thanks, Julie. That's really helpful feedback. Thank you. Liz, let me come to you now. I think you wanted to respond to something someone said earlier.
Yeah, really, in one sense, to support what Anne was saying, that a group of people who then send a delegate effectively to the meeting might be a good idea, and I'm inclined to agree that giving them non-voting rights would certainly take pressure off them being blamed for whatever happened or anything like that. And I do know of organisations who've run sort of similar things where customer service issues are raised, and that people could turn up and talk, and things can be carried forward. And then feedback comes. I think what would be essential is that whoever ended up, if there is a representative or whatever we want to, or delegate, whatever we want to call them, on that board, that there has to be report back in writing, in the sense of email or whatever, or on the website, to say exactly what happened. I mean, because that actually is the key thing about getting confidence in what you're doing, that you report the good and the bad and how the arguments went. You don't have to sort of do a detailed account of this, so-and-so said this, so-and-so said that. But as long as you produce the outcome and mention particular points that were raised, so that the minutes can clearly reflect what happened. I'm speaking from experience here, by the way.
Thanks, Liz. That's, again, very helpful. I guess we're, as a board, we're really keen that we can put in place something that is sustainable and meaningful. We don't want to just have someone on there just to be able to tick the box and say we've got a public representative. It needs to be a meaningful position, and it's just finding a way that we can do that in a way that we can support it. Tim, I think you've joined us a bit late because you had another meeting. Do you want to just quickly introduce yourself and then ask whatever it is you have?
Yeah, and thanks, Chris, and yeah, apologies I couldn't make it earlier. Tim Fielding, I'm Deputy Director of Public Health in Leeds, reasonably recent in post, so I'm fairly new to this board structure, but yeah, really glad to be involved. Yeah, I suppose it's just an observation. Obviously, I've come in quite late to the discussion, but I've had quite a bit of experience around that sort of laying public representation on various different boards. I suppose it was really just a comment and an observation. One of the things I've been really mindful in over the years of this is there is a real danger or tendency to have people who are genuinely sort of public representatives who've never haven't necessarily had any involvement in those kind of structures before, versus people who are now members of the public but are ex-professionals in that world who feel very, very comfortable, bring a degree of comfort, but actually often in practice end up being a sort of another pseudo professional, although they're now retired and not in it. And I recognise how we get into that, but it's just being quite open-eyed about managing that dilemma, because I don't think you know there's pros and cons with both model, but they are two very distinctly different models in my experience.
Completely agree. Yeah, completely agree. It's really difficult. It's a real difficult balancing act. But yeah, it's a real challenge. We've worked really hard with the volunteers that we had at the CCG. We did a lot of training with them around the needs of diverse communities so that they understood that, you know, there was an experience beyond their personal experience. And I think that we did really well, and people were able to step out of their personal experiences and think about the needs of the wider community in Leeds. But it's a challenge, and it requires a lot of work. So
and equally, if people have got that professional background, you might need to discount them or really manage them to not bring that professional background into it, and still continue in that sort of pseudo professional role, even though they're now technically a lay representative.
Yeah, thanks, Tim. It's a really helpful comment. Kath?
I just wanted to agree, as a volunteer, my background had nothing to do with health. And so years ago, when I thought of volunteering, I thought I had nothing to give on the NHS. But actually, when I worked with Chris and the team, and I responded to a very specific description of my role, I could work very comfortably. I didn't feel that I was responsible, as you described. I felt I was the spokesperson and the representative, and I wasn't to have a hobby horse. I didn't bring my personal agenda. If I tried to do it, I was stopped. You learn that, and I had training. So, but I do think that these boards, this is just a personal opinion now, taking my volunteer hat off, are going to have to be very nimble when it comes to making decisions at the right time and at the speed they need to. And so I really worry sometimes that decisions by committee after committee can be very time consuming. And so we need to have confidence in the structure that we set up, that the person who is going to be on that board has a very defined role, is trained, and knows exactly why they're there and what their contribution needs to be. And that role then might need to have, which we didn't have before, Chris, but might have to have some dimension that then feeds back to the other people that you're describing. And so they become a bit more of a bridge. That's all I'm taking away from this. Thanks very much.
Yeah, very insightful. Thank you. Any final comments or thoughts? I'm really pleased that all of our professionals have not spoken, which is really nice. I think it's most of the voices we've heard have been members of the public or volunteers, which is very refreshing. I think someone may have their hand up. Does anyone have their hand up? Anne, and then Julie, I think.
Yeah, one really important thing, Chris, and it will apply to Julie and the lady who joined us, whose family were in the Wakefield home. In Rothwell, we're LS26, Garth's LS25. We're on the boundary. Invariably, no matter what emergency service you ring, you are taken to a Wakefield hospital because we're 2 miles away from them. You don't have a choice. The ambulance just said that's where you're going and that is it. So you need to bear in mind that although some of the things we've discussed doesn't really relate, we are just on the cusp and with no choice. So we need to bring the boundaries of the area in so that people in Garforth towards Tatcaster and North Leeds, because North Leeds, Ockley are sent out more towards Bradford. So I just think we need to be aware of it. Thank you.
Thanks, Anne. Is that just, has anyone got any thought? Oh, Helen, are you going to rescue me and come up with an answer to that?
I can try and answer that if you like. So for all we are the ICB in Leeds, our care providers are not just limited to Leeds, and inevitably we have a number of care providers that go outside of that boundary. So the majority of our planning and our relationships with those providers is usually within Leeds, but you're absolutely right, Anne, because we cannot forget that we have a number of hospitals and services sitting outside that boundary, whether it's Wakefield, Harrogate, Bradford. We cross into all those areas, and we are effectively still commissioners of those services. So we are still responsible for the care that people who reside in Leeds still receive, even if it's outside of the Leeds boundary. So it may not happen at the same scale, but it's still important, and it's good to be reminded that we still have a responsibility to do that. So thank you.
Thank you very much.
Okay.
Thanks, Helen. Julie.
I'm not quite sure how mine fits in there, but it's just with regard to what we are telling you today. And you're sort of saying, oh, well, we'll follow up with this, we'll do that when we're putting suggestions in. Will we get some feedback on that?
Yeah, good question. Absolutely, you will. I'm going to go through next steps when we've finished this conversation and outline how that's going to work. But I can do that now. And the idea is that at the end of this, we will be evaluating the session. So we'll send you an email with an evaluation. We'll also be sending some information out about, with the insight report so that you can have a bit more of a read through, because I'm aware we've covered a lot in this session and it's quite complex. I guess it's up to you guys, but my suggestion will be that we set up another meeting for this group, maybe with less of the professionals, but mainly just the public. And we set that up in maybe January and come back and we can start to develop this conversation and talk about what's happened as a result of this first workshop. And hopefully we'll have some outcomes by then. I don't know if that's what you were expecting or you would like something different, Julie?
No, that would be good, thank you. I wasn't expecting it, but I was thinking it would probably just be a written thing, but yeah, that would be good.
No, I want this to be the start of a conversation, and the people in the room, if they're happy to keep coming back, I think that it'd be useful for us to meet. It might be quarterly, just for an hour, to talk about what's happening and develop this approach going forward, and we can start to feed into the board. And it might be that we ask occasionally Jill to come to those meetings to talk about the work that she's been doing at the board. I think that'd be really helpful.
I'd really appreciate that, thank you.
Okay, well, I've kind of gone through the next steps. This isn't the end, this is very much the beginning, and we've got your email addresses, so we will be in touch with you about meeting again. But I think that's what we do sometime in January, probably after Christmas. I don't know if anyone's got any other thoughts before I hand over to Jill to sort of close the session. No? Great, over to you, Jill.
Thank you, Chris. So first of all, again, just thanks to everyone. I think that's been lots of really rich conversations and it just shows how important it is to have kind of non-clinicians kind of contributing so we can hear the other side, which is so much more relevant and quite often that we probably miss. But yeah, we need that narrative coming from the public to help us kind of really shape our services going forward. So that we had quite a lot of information obviously about the gaps being identified, certainly learning disabilities and serious mental illness, and how we actually kind of interlink with those other boards to make sure that we're working together. The feedback about the traveller community as well is something really important to take away, and of course it's kind of on the ethnic minorities, how we really need specific kind of focus on those areas as well to support it. So that was great. On the outcomes, obviously you all need time to have a look at those outcomes, I think, and have a bit more time to digest it. We appreciate it was too much to take on this and then have your views coming back from there. And I suppose the public representative, we haven't got an answer, have we? And it just shows how difficult it is about how you have the representation on the actual board itself. But it's looking like a combination of things going forward. So so thank you, really good. We'll take this away, and it gives a lot to kind of think about. And as Chris said, kind of the next steps that have already been discussed. So it's just to say thank you, Chris, for kind of leading on all this, and thank you everyone for your time and being involved.